The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/DFZ860. Downloadable slides and practice aids are also available.
Welcome to highlighting the vital role of primary care in identifying and optimizing treatment of diabetic retinopathy and diabetic macular edema. I'm Dr. Richard Beezer, Medical Director of Continuing Medical Education and Senior Strategic Advisor of Education Programs at Joslin Diabetes Center, and Associate Professor of Medicine at Harvard Medical School, Boston, Massachusetts. As we all know, people with diabetes are at increased risk of developing many types of eye disease, including retinal disorders. While ophthalmologists perform much of the screening, diagnosis, and treatment of these conditions, it's really primary care clinicians who are in a key position to suggest, encourage, and perhaps even cajole people who need such screening and care to seek out qualified eye care professionals early when treatments have the best chance of preventing irreversible vision loss. However, for most primary care providers, the field of ophthalmology is often conceptually quite distant from the mainstream of your daily practice. So for you to effectively guide people to and during ophthalmologic care, having a clearer picture of what that care entails would be quite beneficial. This educational activity seeks to do that. We'll help you understand the current guidelines for eye care, counsel patients about the importance of timely diagnosis of diabetic retinopathy and diabetic macular edema, learn about several first and second line treatments that can prevent vision loss, and help people with diabetes overcome barriers to appropriate vision care. Joining me today are my distinguished colleagues, Andrew Mushfeghi, Associate Professor of Clinical Ophthalmology and Director of the Vitreoretinal Surgery Fellowship Training Program at the University of Southern California's Roski Eye Institute in Los Angeles, California. Also joining me is Timothy Murtha. Tim is Assistant Professor of Ophthalmology at Harvard Medical School and the Beetham Eye Institute of the Joslin Diabetes Center in Boston. Tim, perhaps you can kick things off with some thoughts on your interpretation of the guidelines for ophthalmologic screening and care for people with diabetes.
Thank you, Rich. What we'd like to start this evening with is a quick review of diabetic retinopathy and some important statistics regarding diabetic retinopathy. I provided you here a slide of what diabetic retinopathy can look like with the sentinel lesions that have been determined from the early treatment of diabetic retinopathy study. These lesions can then help us divide retinopathy into its component parts: non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and macular edema as defined in these boxes. The important thing about knowing these sentinel lesions is we can now place those into a classification scheme known as the International Classification of Diabetic Retinopathy. This helps us to speak about diabetic retinopathy in a common fashion among anybody who is working with our diabetic patients. In addition, by knowing the classification, we can make some predictions as to how diabetic retinopathy may progress with time. And from this graph, we can see that if one has mild or moderate retinopathy, the risk of developing the more vision-threatening forms of retinopathy is quite low. But if one has higher levels, these need to be watched somewhat more carefully. How does one lose vision from diabetic retinopathy? Well, there are multiple ways. These are some examples of how we might lose vision. In the first slide on the left-hand side, we see an example of vitreous hemorrhage. This is very common in proliferative diabetic retinopathy and can result in anywhere from mild to severe vision loss. On the right-hand slide, we see a traction retinal detachment of severe diabetic retinopathy, once again causing significant vision loss and probably requiring surgery to repair. And in the middle slide, we see diabetic macular edema with the classic circinate ring and retinal thickening, common to diabetic macular edema, resulting in moderate vision loss. But these are not the only ways one can lose vision from diabetic retinopathy. We can have ischemic optic neuropathies. We can have venous occlusive disease as a result of diabetes. We can have generalized non-perfusion, as well as other ways to lose vision. Now let's talk about some facts about diabetic retinopathy that are important to keep in mind as we progress through this program this evening. The first is, it is a huge problem. As of 2015, there were 415 million people in the world with diabetes, and it's projected to rise to 642 million. Presently, of the people with diabetes worldwide, 93 million will have some form of diabetic retinopathy, 17 million will have proliferative disease, and 21 million will have diabetic macular edema. So why is this a problem? Well, because diabetic retinopathy can cause severe vision loss and blindness, and in fact, it is the #1 leading cause of vision loss worldwide in the working age population. The problem with it is frequently asymptomatic. So these people will not present with symptoms, yet disease is progressing. When diabetic retinopathy is detected early, though, treatment reduces the risk of severe vision loss to less than 5%. The problem is we're not accessing patients in a timely fashion. From this data about the US, only 63% of individuals with diabetes have annual eye exams, and that's been very stable over many years. Furthermore, the utilization in patients with advanced eye disease is quite low. At 1 year, only 33% utilization for people with advanced disease, and at 2 years, only 45%. So, the rationale to improve our current screening is that we are faced with a tsunami of diabetes, that nobody knows is there, it's asymptomatic. The consequences can be quite severe of blindness, and there's historically poor follow-up among people with diabetes. This is all problematic, and the sad part is we can prevent a lot of this with appropriate treatment. These should highlight the need for improved screening and better access to our patients. Thanks, Rich. Back to you.
Tim, when you say the words timely and asymptomatic, I think that throws it back into the lap of those of us that are taking primary care of people with diabetes, primary care providers, and people like myself, diabetologists. So what can we do to help the process move more efficiently?
So to that end, it's also helpful to review things that can aggravate diabetic retinopathy so that we can be aware of these, treat them, and try and prevent problems. So there are significant risk factors for the progression of diabetic eye disease. Poor glucose control, of course, is the top of the list. High blood pressure, duration of diabetes, well, we don't have much control over that. There are other risk factors also, and they are listed very nicely here for you. Renal disease, high cholesterol, dyslipidemia, abdominal obesity, pregnancy, etc. Just by way of review, to deal with the topic at hand, glucose control is the key to controlling diabetic retinopathy and to preventing problems. The DCCT clearly answered this question. In the primary prevention group, we saw a 76% reduction in 3-step progression of diabetic retinopathy. In the secondary intervention group of these type 1 diabetics, there was a 54% reduction in 3-step progression of diabetic retinopathy, a 47% reduction in proliferative diabetic retinopathy, and a 56% reduction in the need for photocoagulation, with a 23% reduction in macular edema. And this held true in the extension study of the DCCT, the EDIC study, even though the hemoglobin A1Cs tended to move together after the study, the positive effects still were present 10 years after the initial study. The companion study to the DCCT was the UK-PDS study, which looked at type 2 diabetics, and their results were very similar. With intensive control, they saw a 29% reduction in the need for laser, 21% reduction in 2-step progression of diabetic retinopathy, 24% reduction in the need for cataract surgery, 23% reduction in vitreous hemorrhage, and 16% reduction in blindness. And once again, they too saw continued benefit after the study, even though there was convergence of the A1C levels. So the overall microvascular complication rate was 25% lower in subjects on intensive treatment. And the most important point, and to answer your question of what you as diabetologists and primary care people can do, is that for every 1% decrease that can be achieved in our diabetic patients, we can see a 37% reduction in microvascular complications. That is dramatic, and that is really where we want to aim the control and the treatment for our diabetics. Rich, back to you.
Thank you, Tim. As we think about this, though, obviously screening is important, and I know there are guidelines for screening that you guys follow, and that we in the primary diabetes care provider group should be aware of. Andrew, perhaps you can talk us through some of the guidelines that we should be knowledgeable of.
Thanks, Rich. That's actually a great transition into what I would like to talk about today, which is starting off with common screening tests for diabetic retinopathy. And while many of us remember learning how to use the direct ophthalmoscope in medical school and internship, it's not commonly used on an everyday basis in our clinical practices by non-eye care professionals. And similarly, and the reason why is that it's difficult to do in an undilated patient, and you can't see much of the retina, so it gives you poor sensitivity despite its high specificity. Visual acuity, on the other hand, is also something that we can do very easily, but it unfortunately does not give us the information that we're looking for. To get the good information, we really need to have a good look at the retina in order to determine that there is retinopathy present or absent. And the way to do that is with a dilated fundus exam or through fundus photography using non-mydriatic fundus cameras. This yields good sensitivity and good specificity against the gold standard, which would be the dilated fundus exam by an eye care professional. Now, there are many different organizations who weigh in on how screening should occur for diabetic retinopathy screening, and one of those is the American Diabetes Association. And there is a lot of agreement and some disagreement. We'll review that a little bit here. For type 1 diabetics, because they tend to present rather acutely, generally they don't need their first exam until within 5 years of their initial diabetes diagnosis. Type 2 diabetics, because they may have been walking around undiagnosed with diabetes for several years, it's important that a type 2 diabetic patient has their initial screening exam shortly after diagnosis, certainly within that first year after diagnosis. And then for both cohorts of patients, if no diabetic retinopathy is present, then we can make sure they come in at least every 1 to 2 years. The ADA says every 2 years is fine, and there's some disagreement with the other organizations. Now, if diabetic retinopathy is present, then the level of severity will dictate the frequency of the subsequent visits. For patients who have diabetes during pregnancy, they require baseline examinations and then once every trimester. Now, the American Optometric Association has very similar guidelines with really follow-up at annual intervals as opposed to biannual for those without diabetic retinopathy. The American Academy of Ophthalmology, again, has very similar guidelines as to the ADA, recommending a at the time of diagnosis exam for our type 2 diabetics and within 5 years for our type 1 diabetics, and once every trimester and at baseline during pregnancy. And so where we really see agreement is that type 2 should be screened at the time of diagnosis. Type 1 patients should be screened really within the first 5 years of diagnosis. And then pregnant patients should have their screening tests really at baseline and then once every trimester subsequently. Where there is some disagreement or where there are some knowledge gaps is the ADA says it's okay to go as long as 2 years if no diabetic retinopathy is present at baseline, whereas the other organizations suggest annual exams for those without baseline retinopathy. There's also no real strong consensus as to the present role of telemedicine in diabetic retinopathy screening across these societies. So that's something that we'll look for alignment on as we move forward.
Andrew, the guidelines are great, but I know from my practice that I'll recommend ophthalmologic care or screening, and patients sometimes won't actually do it. What are the barriers and the challenges that we can all work together to overcome?
That's a great point, Richard. And certainly we've seen that despite all of the work that's gone into devising these guidelines, as you point out, in everyday practice, too, we see that screening levels are unacceptably low. Fewer than 60% of U.S. adults with diagnosed diabetes are actually receiving the recommended annual dilated eye exam, which may sound good on the surface of it, that more than 50% of patients are getting it. But on the other hand, our goal is that everyone should be having this. So it's really low. And the question is, why does this occur? Well, there's denial by the patients. There's lack of patient awareness. Even though we've taken steps to increase patient awareness and the consequences of sort of missing the screening exam, we still see these low levels of adherence to screening guidelines. And it's not just the patients who lack this awareness and maybe lack some of the knowledge necessary to make an informed decision. A lot of our primary care providers are in a similar boat. When we look at a recent study of primary care providers who were surveyed for their knowledge of diabetic ocular disease, while they did reasonably well overall, scoring 81%, they did very poorly on the knowledge of risk factors and complications, and just okay with respect to their knowledge of clinical findings, screening, and prevention. So since they're at the front lines of sort of guiding our patients to what they ought to be doing, it's important that we improve the educational outreach to our primary care providers, as well as provide pragmatic knowledge for our patients. And when we survey patients as to, why don't you go and get the recommended eye exam, when you look at the big pieces of the pie that explain it, 40% of patients say, well, I didn't really think about it. I don't really have a reason to do it. There's really no need to do it. And then about a third of patients will say that it was a financial consideration or a lack of insurance coverage that prevented them from following through on it. And then there were some more pragmatic reasons, such as transportation issues, logistical reasons, couldn't get an appointment, and 1 in 5 patients had other reasons for why they didn't do it. One solution to this may be telemedicine. I alluded to that earlier, and we're trying to lower the threshold that it takes for a patient to decide to get checked. And, we can do this with digital non-mydriatic cameras, and that means they don't need to have their eyes dilated in order to get an adequate image. This has been done at your institution as well as other important public health outreach programs throughout the country and throughout the world. But we don't have great studies yet demonstrating the effectiveness of this in an urban safety net healthcare system like the place I work at, LA County. And so my colleague Lauren Daskovich recently carried out such a study at our program, going to satellite offices, having these non-mydriatic cameras, picking up these images, sending them in, and then having optometrists and ophthalmologists adjudicate the image findings. And what that did was it allowed for fewer in-person eye exams and more outpatient screening tests. And what they did was basically that it really did two things. It improved the screening rates dramatically. As you can see on the right side of that vertical line, you can see that the different clinics, their screening rates went up dramatically compared to before the initiation of the telemedicine program. And it also reduced the period of time that it took to get that screening performed. So we really need physicians and all healthcare providers, physician extenders, and the like, to work together with our patients to improve these screening rates, because we know that we're missing patients who have preventable vision loss disease that could be preventing them from having a substantial vision loss if only they were coming in and getting screened.
I think you made some very good points, Andrew, and I know from my perspective as a diabetes specialist, we have a lot of patients that come in. I do the review of systems, and as part of that, I say, have you seen your eye doctor? And of course, you have to make sure that it's a dilated eye exam and just not somebody that's giving them their eyeglasses.
Yeah.
And I think just getting into it in a little more depth is important. Any thoughts on that, either of you?
Yeah, that's an excellent question, and there's a lot of confusion when you say, "Did you get your diabetic eye exam?" The patients may not be able to quickly make that distinction, and so what would be nice would be if we had a universal operational definition of what it meant to satisfy the screening requirement, so that when we ask the patient, we know we're all speaking the same language when they say, yes, I did do that diabetic screening eye exam. But you're right. You can ask them about dilation, but they may have had a telemedicine screening program where it was just a non-mydriatic camera, and they may not be able to pick up on that nuanced difference.
And Tim, I know that you and I both know from working together at Joslin that there are a lot of things that I, as the diabetes care provider, can do to help. And we learned a lot from our experience with the DCCT that we need to have aggressive medical management, optimized glucose control, blood pressure control, and so on. What are your thoughts on that?
I think the studies speak for themselves. It's clear that the treatment of choice for diabetic eye disease really is prevention. We in ophthalmology tend to approach this disease at the later stages, but the adage of an ounce of prevention is worth a pound of cure clearly applies to this group of people. The problem is, as we're discussing in this particular section, we don't have access to all of these people. So I think, as you have outlined and as we've been discussing, better access to patients is really the key here. And once we have access, then we can start to do better in terms of sugar control and in terms of treatment.
You mentioned the word communication, because I think that's an important point. Tim, you and I working at Joslin have the advantage that we use the same electronic medical record. So I can click on your notes, and if I can decipher some of the technical part, I can at least get a sense as to what it is you're thinking is going on. And I can also look at the interval of between visits as a clue as to how severe you think things are. But in the non-Joslin world, what would you recommend to the primary care providers to try to communicate with the ophthalmologist to get some information?
Well, I think that's on the ophthalmologist to make sure that that connection occurs, because we really do depend on our colleagues in primary care and endocrinology to help manage these people. So for my purposes, if I can, I will either send a letter to the patients, but I also have some difficulties with that because for various reasons, letters may not make it, doesn't get out of my office, gets lost in their office. So I actually trust most of my patients, and I will print out a copy of that day's visit from the electronic medical record, and I will hand it to them, and I will say, make sure that your diabetes doctor gets this. My notes are fairly straightforward. I think they are fairly readily readable and understandable.
Yeah, they are, Tim. They are. Let's take a look at some of the things on the therapeutic horizon. There's some science behind the diagnosis and treatment for diabetic retinopathy. Can you comment on that a bit, Tim?
Yeah, so I think the first thing we need to know is how do we as ophthalmologists go about diagnosing what's going on in the eyes? As mentioned previously, we really don't depend so much on symptoms because they really don't show up till later. Now, if they're there, then we certainly pay attention, and that certainly raises a red flag for us. Symptoms could be anything from floaters, flashes of light, decreasing vision, blurred vision, dark spots, visual field loss, blindness, distortion. But these are not necessarily diabetic all the time. There are other things that may potentially cause this. So this is what a normal eye might look like, a nice fundus photograph of a healthy retina. And on the right, next to that, we see a picture of what we call an OCT, which is a imaging modality of looking at the retina in cross sections. And I'll go into that in a little more detail a little further on. Amsler grid testing is a great way of getting a good sense of what may be going on. And of course, the patient's report of what their vision is compared to what they had been used to for the vast majority of their life, as demonstrated in the picture in the lower right. Now, if they have macular edema, which is shown in the picture on the upper left, they have that nice circinate ring of hard exudates, which is very classic for diabetic macular edema, along with swelling in the retina. But on the upper right, we see an OCT picture of what that macular edema looks like. And you can see how there is swelling in the retina, throwing the retina into folds and valleys and ripples. And that very nicely shows and translates into the Amsler grid changes that we see here. And of course, the vision that the patient reports is, of course, blurred, distorted, missing pieces, and assorted other descriptions. The symptoms that you might get in proliferative disease can run the gamut. On the top two slides, this is an individual with proliferative disease who's had bleeding in the retina, which you can clearly see, but the bleeding is off to the sides and it's not in the visual field. And this is a patient who has significant disease, yet is totally asymptomatic, and they have no signs in their vision that would warn you that there's significant disease. In the lower level, we see a bit more advanced proliferative diabetic retinopathy, where there is significant bleeding that has broken into the vitreous, creating floaters, that, as we typically refer to them, which are these black spots that float around in the vision, obscuring things. And if you'll notice, there is a preretinal hemorrhage inferiorly. This is causing a very large area of scotoma for this patient. The bleeding sometimes can be so dramatic where there is no view of the retina, the patient can barely see a light in front of them, and of course we as ophthalmologists can't see into the eye either. So what are the diagnostic tests that we do? Well, of course, history is key, as it is in everything, but on physical exam, we'll start with a slit lamp examination and biomicroscopy. This is where we'll look at the retina in 3D using a magnifying glass to really look at the fine details of the posterior pole. I often refer to this with my patients as I'm looking at the trees in the forest. We'll then go on to look in the eye with an indirect ophthalmoscope. This sort of lets us get a whole fundus view of the eye, much like the pictures that you saw. And I often refer to this as looking at the forest. And this can allow us to see peripheral disease from diabetes and other pathologies that may be outside of direct ophthalmoscopy. As I alluded to before, OCT is a new modality of imaging. Well, not that new anymore, but it is key, and it has really revolutionized the evaluation and treatment of individuals with retinal diseases, and in particular diabetes. Of course, fluorescein angiography has been around for many years, and this allows us to follow the flow of the fluorescein dye as it passes through the eye, and this will highlight abnormal vessels, leaking blood vessels, and areas where the blood may not be flowing at all. So what is OCT and how does it work? Well, OCT is a technology that allows us to visualize the retina using incident light. So we'll shine a light into the eye, and the light will bounce back to the receptors and will give us a view as you see in this picture. This is extremely fine detailed. It has about 9 micron resolution. And we can actually measure the degree of swelling that we have here. So this allows us to characterize the degree of swelling and to allow us to follow the response to our treatments. Of course, there's fundus photography, which has been around for a long time, that is readily used in ophthalmology. On the picture on the left, you can see 7 little blue circles. That represents the standard 7 fields of the ETDRS. That has been now supplanted by the use of wide field fundus photography, which allows us to evaluate the peripheral retina, and we have now come to understand that there is significant disease in the peripheral retina that may help us and guide us in terms of what treatment we may suggest. We can also do wide field angiography. Rich?
Thank you, Tim. You know, there are a lot of new treatments that are out there now as well, and I know there's a lot of confusion and misunderstanding about them. So, Andrew, can you perhaps give us a walking tour of what's going on out there for treatments?
Sure. Thanks, Richard. That's a great segue. And, really traditionally, the management of diabetic retinopathy was the management of diabetes and the whole patient. And in recent years, we now have additional therapies available to us, and they're really largely based upon the role of vascular endothelial growth factor, or VEGF, in diabetic retinopathy. And in what we see in diabetic retinopathy patients is that there is abnormal upregulation of VEGF in patients with DR. And what that results in is leakage of blood and lipid and serum into the retina itself, which causes retinal hemorrhages, inefficient delivery of oxygen to the target tissue in the retina, and also swelling of the central retina or macula, causing diabetic macular edema. And this is a major problem. And so this is a good, rational biologic target for the management of diabetic retinopathy. And when we look at the different things that we end up treating in diabetic eye disease, probably the biggest target is the most common cause of vision loss in diabetes, which is center-involved diabetic macular edema. And for this, we use drugs that block VEGF, and we do that intravitreally through injections. Similarly, we can use intraocular corticosteroids, in addition to the old ways of managing center-involved diabetic macular edema with focal or grid macular laser photocoagulation, which tries to achieve the same thing as anti-VEGF agents does, but it does so through photocoagulation instead of biological effect. And then we're also trying to prevent vision loss in diabetic retinopathy from high-risk proliferative diabetic retinopathy, or PDR, and we still tackle that through tried and true means such as peripheral pan-retinal laser photocoagulation, which decreases the ischemic drive driven on by all of this upregulated VEGF. But nowadays, we also use anti-VEGF agents delivered intravitreally every 1 to 4 months to try to quell the effects of proliferative diabetic retinopathy. The question is, do those same agents have an earlier role in the management of the less severe non-proliferative diabetic retinopathy? And it seems like they might, and we're starting to use them more and more for selected patients, just like we used to do early PRP laser for patients who maybe didn't quite yet meet the threshold for treatment like they would if they were already with PDR. But perhaps their other eye had already progressed and had a bad experience, and so with the second eye you might want to be more aggressive. We do that in selected cases. Now, with respect to diabetic macular edema, we have outstanding data showing that intravitreal anti-VEGF therapy is extremely effective. We can see on the panels on the right that patients are seeing better. Their vision is improving very quickly over time after exposure to each of the anti-VEGF agents. And similarly, we're seeing decreases in their degree of retinal edema or macular edema, as we can see on the panels on the right. So vision goes up, retinal thickness goes down, and that's what we've come to expect with these extremely effective anti-VEGF agents. And they all seem to be relatively similar to one another, with just minor differences in efficacy over time. What about corticosteroids? Well, they're not really first-line therapy for diabetic macular edema because they do have some negative side effects such as intraocular pressure elevation and cataract formation. But they are quite effective, and so we do reserve them as agents to be used either as adjuvants to anti-VEGF therapy or when anti-VEGF therapy fails to deliver the adequate efficacy punch that we're looking for. And we see here that there's nice improvement in vision over time with the dexamethasone intravitreal implant, and it has a positive effect on the OCT central retinal thickness as well, similar to what we'd seen with the anti-VEGF agents. That's for diabetic macular edema, and you really have to think of diabetic eye disease in really two major camps: diabetic macular edema and high-risk proliferative diabetic retinopathy and all the bad stuff that is the sequela of that. And here we're seeing an example of a really severe traction retinal detachment involving the center of the retina, right in the middle of the macula. So this is a patient who, if we were to do nothing, is going to have really no chance of vision improvement and may actually continue to lose vision. So in this case, really surgical intervention is indicated, and that's going to be with so-called pars plana vitrectomy to repair complex traction retinal detachment. And right now we don't have a way of sort of preventing that other than with anti-VEGF agents or pan-retinal laser photocoagulation along with systemic disease control. Now, pan-retinal photocoagulation works. You see the PRP scars here in this patient in the top photo, but those PRP scars are not without consequence. It can constrict the peripheral visual field. It's painful to administer and for the patient to receive, and it does have some complications like rupture of Brooks membrane and abnormal blood vessel growth proliferation. So there are some downsides to this tried and true approach, even though it is quite effective. And that's where anti-VEGF therapy may come into play. When we look at the patients who were studied with aflibercept for diabetic macular edema treatment, there were patients who had nice benefits to their diabetic retinopathy score. So if you look on top, this was a patient who had baseline, had a lot of macular edema and a lot of diabetic retinopathy, but by the end of the study had almost no macular edema and almost no diabetic retinopathy. And it's anecdotal observations like this one that lead us to think that this might be a good treatment for just diabetic retinopathy in general. So what about combination therapy in diabetic macular edema? And as I alluded to earlier, we often will use, for example, corticosteroids in patients who just did not have the optimal response. And this would be sort of in addition to our anti-VEGF monotherapy approach. And this makes sense because, we know that there are other inflammatory mediators that are upregulated in diabetic retinopathy other than VEGF that are perhaps more adequately covered by corticosteroids effects. And so we do keep that in mind for patients who are having an incomplete response with anti-VEGF therapy, although we do have to keep in mind that there are some adverse events such as cataract formation quite predictably several months after therapy is initiated, and a very significant proportion of patients can have elevated intraocular pressure. And so we need for patients to be aware of that and for doctors to be aware of that as well. Now, intravitreal anti-VEGF injections have a very safe ocular and systemic adverse event profile. The risk of endophthalmitis with injections like these is roughly 0.02% or 1 in 5,000. And although there is a risk of IOP elevation after sustained repeated dosing of these agents, it's a relatively low risk, not nearly as high as what we see with intraocular corticosteroid therapy. And in general, patients are going to receive these injections roughly once every 3 months, or up to once every 3 months. Certainly, some patients need it every month. Other patients need it every 2 months. And then how do we decide how frequently some patients need it compared to others? Well, we examine the patients at regular intervals. We perform tests like Dr. Murtha mentioned earlier, optical coherence tomography testing, angiography testing, and these help us in deciding how frequently the treatment effect is going to need to be helped out again with another injection. Now, as you mentioned, we have outstanding array of medications to choose from in managing diabetic retinopathy and diabetic macular edema already. But what's really exciting is that there's a whole new slew of drugs coming down the pike that are going to help us by being a little bit stronger and having a broader spectrum of the cytokines that they modulate, but also may be longer lasting in duration. So instead of treating patients 6, 9, or 12 times a year with our existing therapies, we might only be treating them once or twice a year with some of the therapies that are coming down the pike. So super exciting to see that type of research translating into benefits for our patients in the coming years.
Fascinating. Let's come back to the role of the primary diabetes care provider, the primary care provider, the diabetologist such as myself. I know that when I first started hearing about the therapies with injections, the thought was a little cringeworthy. And I know that injecting into the eyeball is something that patients sometimes cringe with, but I know it's really not nearly as bad in reality as it sounds. What advice, this has come from either of you, Andrew or Tim, what advice would you give to the primary doctors as to how to describe the therapy so that we take away that cringeworthiness as a barrier to patients?
Yeah, I would tell you maybe don't even go there because I think we're very good, once we get the patient, we're very good at explaining to them how the bark is worse than the bite in terms of the injections. So I might just suggest to the patient, look, we need you to go see your ophthalmologist so that they can discuss with you all of the great treatments they have available.
Yeah.
And just kind of leave it vague. And then when we get there, when they come to see us, we can sort of nuance it from that point forward.
We'll leave it up to you guys. It's something similar to the way I approach insulin. I say to people, what is the worst thing about insulin? And think for a minute, and I say, anticipating it. Once you have it done, it's not nearly as bad as you worry about. And I think that's the same with this sort of a thing.
Sure. And one thing I found very
Tim.
helpful too, that I think would be a good course for the primary care and endocrinologist to consider is that the internet is a wonderful source of information, and there are multiple sites that have patient testimonials and videos of actual injections, and I think many patients really find that to be very reassuring. So I think that's another way that, and I'll often use it in my own practice. So something to think about.
Yeah, and I know that once people get started, I'll have patients that sometimes are iffy in terms of whether they show up for visits or not, and they may disappear from my schedule for a while. Then they'll reappear, and I'll look through the history of visits, and I'll see every one of those ophthalmologic exams or sessions they showed up for because they realized how important it was. They were skipping me, but they were going to you guys. So once they realize the importance, they start doing it. Any other comments in terms of general care? Because I know that from my perspective, there's an old teaching when I had dark hair and was a bit younger that if they had eye disease, look for kidney disease. If they had kidney disease, look for eye disease. And I think that's still somewhat true. So we need to do a universal approach to diabetes. Any thoughts from you guys?
I agree with you on that, Rich. To me, the development of diabetic eye disease is sort of the canary in the coal mine of diabetic microvascular disease. And I think that, once the medical team realizes that this is here, then absolutely looking in the renal situation, the cardiac situation, the feet, the peripheral vascular disease, etc. And I think the converse is also true of that. If there are issues developing in the kidney, proteinuria, or whatever, and they haven't had routine ophthalmic care, then I think that should be the red flag that should really push that forward to the referral for ophthalmic care.
I think we have a couple of cases that you guys have brought to us that illustrate how you think and how you treat. Andrew, I think you've got the first one.
Yes. Let me share with you an interesting case. This was a 51-year-old Asian gentleman with type 2 diabetes, but requiring insulin with no known history of diabetic retinopathy. He did have kidney disease, as we were just mentioning, and on to hemodialysis, and suffered a car accident at age 20 that left him with traumatic brain injury, requiring a VP shunt. He also has some other comorbidities. His visual acuity was near normal at 20/40 in each eye, but he was complaining of new floaters in the left eye and has not had previous eye surgery. He wasn't fully cooperative with his first exam with me, But we can see in this color fundus photo in the upper left-hand corner that you just can't really make out the details of the retina very well. And the reason for that was that there was some vitreous hemorrhage present. So that's hemorrhage that's in front of the retina, not just within the retina like we see at the top of that image, where you see some blot and dot hemorrhages there. Now, if you look in the lower left-hand corner, you can see on the so-called fluorescein angiogram a big dark area near the middle, and that's where the vitreous hemorrhage is sort of standing out in relief. And you can see that it's blocking the fluorescence from the retina. And on the left side of that lower left image, you can see that it looks a little bit different than the rest of that fluorescein angiogram, and that's because there's such bad diabetic retinopathy that the capillaries in between the major retinal vessels just aren't having any perfusion at all. And that's just from manifestation of diabetic retinopathy. When we look at the cross-sectional scan in the upper right-hand corner on the OCT, optical coherence tomography test, we see that there's some speckled findings in the vitreous cavity, and that's blood. And then also that the retina is a little bit swollen. When late in the angiogram, we see some leakage on the angiogram. So this patient is the type of patient in the past that we would have just simply performed pan-retinal laser photocoagulation due to this high-risk level of proliferative diabetic retinopathy with vitreous hemorrhage. What we did instead, after a long conversation with the patient and his caretakers, who sort of had an aversion to pan-retinal laser photocoagulation, and they were concerned about his ability to cooperate with that in the necessary fashion, we ended up performing a series of anti-VEGF injections, in this case aflibercept, and we did so quite regularly between 2016 and 2019. And although we don't expect to see a complete reperfusion of those non-perfused areas, you can tell in the 2019 images that there's significantly less sort of leakiness overall on these images compared to the 2016 images. And that also had a benefit to his macular edema. If you look at baseline, you can see that there was quite a bit of macular edema on the color-coded thickness maps, but that calmed down quite a bit with mainly just sort of green appearance on that thickness map by 2019. And what I didn't show you in this case was that the other eye had the exact same thing. So I just, for the sake of brevity, showed you the left eye, but really both eyes were benefiting in this exact same way. And I still treat the patient today. In the beginning, I was treating him every month, but now I only treat him once every 4 months. So this is a acceptable treatment burden for this patient, and he's preserved his peripheral retina without the need for PRP laser.
Very impressive. Very impressive. Tim, I think you have a case of DME.
I do. So this is a case of diabetic macular edema, and we'd like to apply the principles that Dr. Moshfeghi just spoke about in terms of treating these types of eyes. He's a 53-year-old man with type 2 diabetes for 16 years. His A1C is 8.1, and he has severe non-proliferative disease with center-involved diabetic macular edema. Now, you can't tell he has diabetic macular edema from his color photo here because he doesn't have the associated hard exudates, and that's actually fairly common. But I know I can convince you that he has edema when I show you his OCT. Clearly on the OCT there is significant swelling in the macula here with a large central cyst. He has decreased visual acuity to the 20/50 level, and he's quite symptomatic from this. For this reason, it was decided, after discussing this with him, to treat him with an intravitreal therapy, aflibercept. He received 3 monthly injections, and you can see at the end of his treatment here, the edema that he had is dramatically improved, his visual acuity has improved, and his symptoms have improved, demonstrating the effectiveness of these agents. When we use these agents, though, I think there is an awful lot of education that needs to go into treating patients with this. And the first is the fact that this is a daunting treatment for patients in that it requires multiple injections over the course of 1 to 2 or even 3 years. So it would not be unusual to have 7 or 8 injections in the course of the first year, 3 to 4 injections in the second year, and maybe 1 to 2 injections in the third year. In addition to that, I also take the time to discuss the fact that there is a significant proportion of patients who will be non-responders to this treatment. And the problem is we don't know that a priori. So you have to be 7 or 8 injections into this treatment to get the sense that you're not responding after you've changed medications on several occasions. That can be somewhat disenchanting to the patient. And sometimes it can even result in the patient not following up. So it's really important that we work together with these patients. Thirdly, when I treat people like this, I tell them that our treatments are only supplementary to the medical treatment. I tell them that's the cornerstone of their treatment. So controlling the diabetes, controlling the blood pressure, controlling the lipids is really the cornerstone. And to a certain extent, I think patients find this to be a positive situation, because this allows them and empowers them to contribute to the positive response of their treatment. It also brings in the primary care and the endocrinology team to be part of this process. And by helping these patients control their sugars and their blood pressure, the patients look upon this as either an explicit or implicit approval of this treatment course. All of this allows better buy-in from the patients, which helps to keep them in the treatment process, which is very easy to get tired of for patients.
Tim, I think you make some very important points, and it sort of comes back to the interactive theme that we've talked about. And I want to take a look at that again from the perspective of the shared decision making. I know that when I have patients that have gone to you and your colleagues in the eye unit and are beginning to get these treatments, they often come back to me with a reinvigorated desire to improve their glucose control, because suddenly there's a tangible reason for them to want to do this. And I find that sometimes they're a lot more responsive to moving on to more aggressive therapy, maybe taking on multiple insulin injections, new medications, a pump, something like that, so that they can move forward. From your perspective, how do you engage the patient as you're thinking about these treatments in shared decision making? Because hearing how you do that can often help the primary doctor get a sense as to how it's being approached.
So yes, Rich, I agree. Shared decision making is extremely important. And if I can just give you a sample of an episode that I had recently, where a patient with proliferative disease was recommended to have injections. I failed to follow up into the patient's ability to continue with this treatment. We got into 2 rounds of treatment, and then this patient became lost to follow-up. So here's a patient with significant disease that is totally undertreated with only 2 injections and lost to follow-up. I really neglected to look into this patient's needs in terms of his life, his work, his family, his finances, and for that, he may end up in trouble. So it is important to work on shared decision making so that perhaps in this case we would have come to the conclusion that laser treatment was a better way to go for this patient.
But that all feeds into the optimal use of the current agents and balancing one treatment versus the other, and perhaps multiple treatments, Tim. Is that correct?
That is correct. And the American Academy has created a nice table for an outline of how we might recommend treatment. But it's important to understand that it needs to be individualized, as I just indicated. We in ophthalmology treat disease at the late stages, proliferative diabetic retinopathy and diabetic macular edema, because those are the vision-threatening stages. But prevention, of course, is the better treatment, and that's where we rely on our colleagues in endocrinology and primary care. In ophthalmology, we are actually starting to dip our toes into the pool of prevention, and Dr. Moshfeghi alluded to this earlier in terms of a trial looking at preventing diabetic retinopathy. So our goal is to take a 20th century success with laser treatment and all the side effects that it entails to a 21st century treatment where the eye appears to have had little or no problems. And to do that, there is an emerging therapy that was looked at in the Panorama study, and this evaluated the use of aflibercept to reverse the anatomic changes of diabetes. The concept of this was derived from observations in the RISE and RIDE and VIVID and VISTA trials, which demonstrated that these intravitreal injections were effective for DME, but also saw significant improvement in the diabetic retinopathy score. So the question was, could these intravitreal agents be used to improve diabetic retinopathy? And the short answer was yes. In the course of this study, approximately 80% of people had at least a 2%, a 2-level improvement in their diabetic retinopathy score with the use of either every 8-week or 16-week injections. But the problem was it had little or no impact on visual acuity and visual function, which made it somewhat less compelling. But the study then went on to look at whether using these could prevent the vision-threatening forms of diabetic eye disease that we've been talking about. And as you can see from this slide, there was a significant improvement of preventing these vision-threatening forms of diabetic retinopathy. So this is fairly new data. It will be interesting to see how this is assimilated into our retinal practices. And I look forward to having your patients tell you about this.
Thank you.
Rich?
Andrew, let me throw this over to you now and get your sense as to the factors that influence individualization of treatments.
Thanks, Rich. A lot of different factors go into the decision-making process that ophthalmologists and retinal physicians go through when they're choosing an anti-VEGF approach versus a laser or corticosteroid approach. And with respect to the control of diabetic retinopathy, not so much diabetic macular edema, but with controlling diabetic retinopathy, the really important factor, as Tim mentioned, is how reliable is this patient at keeping appointments and following up and making sure that they're staying on track with the therapy. So that's a big factor, because with PDR, proliferative diabetic retinopathy, if you start anti-VEGF therapy but don't finish it or don't transition to laser, you could be in a world of trouble with a irreversible loss of vision that's quite severe. And the nice thing about laser is that even though it does have its downsides, once you apply it, it has a sort of a permanence to it for patients who respond to it nicely. So that's one factor that we keep in mind, but we also look at, how have they done with similar treatments? Have they had a positive benefit to anti-VEGFs in the past? Do they have contraindications to receiving corticosteroids? And how do they feel about the treatment burden? Are they someone who does not want a lot of injections, really hates the injections? Then you have to think about that when you're making your treatment decisions. But then also the severity of their overall disease, their ambulatory status, their ability to come to appointments. And, so we do think about ocular comorbidities. Are they pseudophakic? Have they already had cataract surgery? If so, that lowers my threshold for choosing a corticosteroid. Do they have other problems that are affecting their vision, such as macular pucker, macular hole, or other things I need to take into consideration? So we have to think about all these different factors when deciding which drug may be appropriate for the diabetic eye disease management in these patients.
And ultimately, Andrew, the goal is patient satisfaction and adherence to therapy, isn't it?
It is. And, what we've learned from these rigorous registration trials for anti-VEGF agents, as well as other treatments for diabetic retinopathy and diabetic macular edema, is not only that we're improving visual function, but we're actually improving their activities of daily living, as has been shown in multiple quality of life studies that have been performed as part of these studies. And when we look at comparative effectiveness studies, such as diabetic retinopathy protocol T study, we see, as you pointed out, a really good adherence to patient visits with 94% of patients having a 100% visit constancy rate, and that 51% of patients were on time and very few patients were late for their follow-up appointments. So this is telling us that patients are engaged in their therapy because they feel it's helping them, and so they really want to make sure that they're sticking to the program.
As I said earlier to Tim, they go to you guys, they may not come to me. We've got to encourage them to work with the whole team. We're going to take a few questions for the faculty now. And we're going to start with one that's always been an intriguing one throughout my career. Why do some patients do well with a higher A1C or hemoglobin A1C? And I'm assuming the do well means from the standpoint of retinopathy, but it may mean for a lot of other diabetic complications as well. And perhaps I'll take a stab at this first and then let others comment. Diabetes control, optimizing diabetes control has always been the goal of those of us that treat diabetes. And in fact, there's a lot of data that shows that improved control does make a difference in reducing the risk of many complications, ophthalmologic complications, renal complications, and so on. With respect to the cardiovascular complications, the macrovascular disease, we also, of course, have to think about lipids, blood pressure, weight reduction, and so on. But there are always the exceptions that prove the rule, and we always have patients that we can show that will have a higher A1C and yet escape the complications, and then those that have worked hard and gotten a low A1C and have still had a lot of complications. And we don't fully understand what other factors there are that may be contributing to the increased risk of complications in these people. There is a study going on at Joslin. Dr. George King at Joslin is conducting the 50-year medalist trial. We give a 50-year medal for those people with type 1 diabetes if they've had it for 50 years. And many of them have rather minimal complications. And he's trying to figure out what is it about these people that's allowed them to go that long with minimal complications. And that's not just ophthalmologic, but all other complications as well. So while nobody questions that optimizing diabetes control is good for you, it's not a guarantee. Tim, did you have something to comment on that as well from an ophthalmologist perspective?
I think it's pretty much the same that we see in ophthalmology too. There are certain patients who, regardless of their control, seem to do reasonably well for reasons that we can't explain, while the other patients who seem to work hard at it are often dealing with significant issues. I think there are certainly all the other factors that go into the progression of diabetic retinopathy, such as blood pressure and cholesterol and renal disease and what have you. I think they play a significant role, but I'm suspicious that there's something genetic about these people that is either helping them or hurting them, and we have not figured that out yet.
Yeah, I'm a big believer in genetics. I always take a family history, and you see people that have got a bunch of relatives that have got various problems, especially the cardiovascular, cardiometabolic, and you know darn well where they're heading. And I've been in this business long enough so that I've seen them at young ages, and I've seen them age, and oftentimes that's correct. So family history is a very important factor. I think that there are a number of questions here that really get back to what the primary doctor or the primary diabetes care provider, because I put myself in that category as well as a primary care family practice provider. What can they or should they be doing in the office setting? They say their main role is to refer to the ophthalmologist, but why is that important? Why is the handheld ophthalmoscope limited? And how is that limiting in terms of some of the changes in the periphery? Maybe I'll throw this one to Andrew first, and then Tim, you can comment.
Sure. So it's a fair question. And basically what we know is that if you use the direct ophthalmoscope, you're going to have an extremely limited field of view that's highly magnified. You can barely fit the entire optic nerve within your field of view of the direct ophthalmoscope. And just imagine how much retina you're not seeing when you're doing that well-meaning direct ophthalmoscopic examination. And so it takes a bit of time to do this properly, a bit of cooperation. And so it may not actually be all that fruitful for the primary care doctor to actually undertake this, especially since, as the question itself indicates, significant portions of the retina are not being picked up by this direct ophthalmoscopic exam, and that has implications. We know from multiple studies that if you have predominantly peripheral retinopathy, that it tends to be associated with a poorer disease progression and prognosis. And so now you may look and falsely tell the patient, hey, I see no retinopathy. Good news. Well, it's only good news that the parts of the retina that you could see didn't have retinopathy, but it's not good news that you didn't see the rest of the retina. And so I think the number one thing the primary care physician can do in their office is not only make the recommendation that the patient go and see the eye care provider, but actually follow through and make sure that it happened. So maybe you have a designated person in your office who is in charge of making sure that the patient had their diabetic eye exam and what the result of that eye exam was. I think that's the number one thing. Now, you could also get involved with telemedicine outreach programs and have your office serve as a image acquisition site for a eye exam using the camera, which does a much better job than the direct ophthalmoscope. And that might be a more fruitful approach.
All right, one listener wanted to know, does blood work and urinalysis often provide the pointing indicator for referring? I'm not 100% sure what they mean, but I think this gets back to a comment I made earlier that often renal disease and eye disease go hand in hand, to say nothing about the other complications, but renal and eye, microvascular disease. So while I really urge all of my patients to get ophthalmologic screening and care, when I start seeing certain things in the urine, rising proteinuria, dropping EGFRs, that really is an alert to me, not just to send them to the ophthalmologist for a screening, but also to address their renal complications, because that certainly would require more aggressive blood pressure treatment, and I'll often refer them to a nephrologist, and of course watch out for cardiac disease. So I think those screening tests can be a red flag for a number of different conditions. There's a question here that wanted to know, is anti-VEGF causing any adverse effects? Either of you.
So to date, we know that there are some side effects from antivascular endothelial growth factors. Many of these are local, and many of these are actually more a result of the actual injection rather than the medicine itself. As far as the eye is concerned, there are allergic reactions, inflammatory reactions that can occur with these medicines, but they're fairly infrequent. More frequent are the concerns that introducing a needle into someone's eye can result in infections, detached retinas, retinal hemorrhages, cataract formation, elevated eye pressure, vision loss. Fortunately, these are fairly rare. In total, if one were to take all possible complications, it's generally quoted that in about 1 in 1,000 injections, one or another or some of these may occur per injection. So we do take it seriously. We do make every effort to avoid these complications, but even so, things do happen. Beyond the eye complications, there can be systemic side effects, or there is concern that there can be systemic side effects of these medicines because they are absorbed into the system. And that primarily arises from the history of these medicines, which was a medication called bevacizumab, which seems to be which is the father compound of these medications. And in those instances where treatments with bevacizumab was carried out for cancer disease, there were significant systemic complications, cardiac disease, strokes, GI bleeding, etc. Fortunately, the studies that have looked at the use of this have not particularly found that we are finding cardiac or systemic issues above what would be expected from the general population. So I feel comfortable from a systemic standpoint that we are fairly safe with these medications. Andrew, did you want to add anything to that?
No, just to point out that, the systemic agents that are used to treat metastatic cancer are given intravenously in very high amounts in very frequent dosages for a long period of time in high-risk patient groups. And in those groups, they saw elevations of blood pressure fairly significantly, in addition to thromboembolic events and stroke. So fortunately, our studies have not revealed dose-dependent or different rates of these events. By and large, when you look at the different studies for intraocular administration of these medications, which are done, albeit frequently, but done in minute dosages compared to what's being delivered intravenously for our patients with cancer. So the caveat with what I just said is that our studies aren't really powered statistically to determine whether or not there's any statistically meaningful differences with respect to these outcomes. You'd have to have 10 times or as many patients in each arm in order to answer that question declaratively. That being said, in everyday practice, now that we've treated tens of thousands, hundreds of thousands, millions of patients' eyes, we have not seen a epidemic of hypertension or strokes. So they appear to be fairly safe from a systemic perspective after intraocular administration. But the jury is out.
I think we have time for one more quick question. A questioner wanted to know specifically the effects of GLP-1 receptor agonists on ocular complications, and sort of springing from that comes the question about rapidly improving diabetes control, and is that a problem with respect to ophthalmologic complications? Tim, maybe you can comment on that?
So there was concern that these particular group of medicines, which happen to have significant amounts of receptors in the retina, may actually aggravate diabetic eye disease, and there were some reports of that. So a fairly large study was done approximately 2 years ago in Great Britain, looking at the progression of diabetic retinopathy with the use of these particular medicines. Turns out that they really did not find much of a progression, and when they did see some evidence of progression, it was actually felt to be more related to the sudden onset of tight control, similar to what we saw in the DCCT. So although it's not definitive yet, it seems to be a reasonable idea that these are medicines that are not having a dramatic impact on the progression of diabetic retinopathy, at least that we've been able to determine so far.
And I know as an investigator from the DCCT, we saw with rapid onset of control some short-term worsening of retinopathy, but long-term the retinopathy was better in the tightly controlled group. Team. Thank you both, Tim and Andrew, for an excellent overview of the state-of-the-art in the diagnosis and treatment of diabetic retinopathy and diabetic macular edema. We recognize that primary care clinicians are inundated with new information in multitudes of topics. However, you both help clarify the current approach to care and evolution of treatments in the complex subspecialty of ophthalmologic care for those of us that aren't in that field. And also thanks to all of you for logging into this program. On behalf of the Joslin Diabetes Center, I'm Dr. Richard Beazer. Thank you for joining us.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/DFZ860. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated.